Muted. Okay. Welcome to the Smart Talk, everyone. Alzheimer's disease, risk, protective factors, and updates on treatments. We're so happy you could be here tonight. And with our wonderful speaker, Michal Schnaider Beeri. And I am going to turn it over to Debbie Lynch for a welcome.
Welcome, everyone. I'm going to keep my introduction to Dr. Beeri very short because I know she has a lot of information to cover, and I know that there's going to be a lot of questions. So just briefly, Dr. Beeri was the director of the Joseph Sangol Neuroscience Center at the Sheba Medical Center in Israel for 12 years. And then she became professor of psychiatry at the Icahn School of Medicine in Mount Sinai, where she was for 21.5 years. And then we were extremely fortunate to have her join us here at Rutgers. And she is the director of the Herbert and Jacqueline Krieger Klein Alzheimer's Research Center at Rutgers University, a professor of neurology at the Robert Wood Johnson Hospital in New Jersey. Dr. Beeri's work focuses on the role of metabolic derangement in brain aging, cognitive decline, Alzheimer's disease, and dementia. Her research spans from studies of dementia to clinical trials testing novel treatments primarily devoted to the prevention of the disease. Dr. Beeri has won numerous professional awards, has over 200 peer-reviewed articles, and has been funded continuously by the National Institutes of Health, Alzheimer's Association, and other research foundations. I had the privilege of having a lunch with Dr. Beeri, and we did not stop talking the whole lunch. And I have been retired for 13 years, and it was just such a pleasure to be able to sort of talk my background again with Dr. Beeri. She was so enthusiastic, and she generously, after our lunch, offered to come and give a talk at my home to friends and family. And I thought this would make a phenomenal smart talk for the AADC. So I reached out and asked her if she'd be willing to do that, and she enthusiastically said yes. So here we are tonight. Welcome, Dr. Beeri, and I'm really looking forward to this lecture.
Thank you for such, oh, am I? Yeah, I'm not muted, that's good. So first of all, thank you for the warm welcome, and I'm coming with all the excitement indeed. And I want to take 30 seconds to tell you what happened with Debbie and that lunch. So we formally meet, and we're sitting and chatting about what I'm planning to do here in Alzheimer's disease and so on. And the conversation keeps going and going. And then at the end, it's a little less formal, and everyone drank a little bit also. So I look at Debbie and I tell her, like, do we hug? And she responded, I'm a hugger. And then it was not formal anymore. So, and Lori, thank you also for walking me through. Lori made sure that I'm be very comfortable here today. So I'm just going to put up my presentation, but already in the second slide, I'm actually going to take it off, and I want to see everyone because I'm going to be asking you a few questions just to trigger your mind, pun not intended. Can you see well? I need to say, oh, I don't see anyone. I usually see at least someone. Can someone just say yes?
Yes.
Okay. So if anyone wants to take a look at our website and see what are the different types of research that we're doing, then I'll be we'll be more than happy to have as many people coming in and telling us if it's interesting and if they're interested in participating in research. Now I'm going to stop sharing for a second. Can I have some issues here because I don't have the Zoom. Let me see if I can do it. Here we go. So I'm not sharing right now, right? Okay. So can I not be in the center? Can I just be regular so I can see as many people as possible? All right, this is better. So I'm going to ask you a few questions, and you just raise your hand if it's relevant to you.
I'm
Okay,
blocked. I can't do anything.
oh, someone has to mute. Maybe Elizabeth or Pamela, who are not muted. Thank you. So the first question is there anyone here that I can see that never forgets names? I love that. I love that moment that everybody kind of smiles with a little moment of embarrassment. No, I forget names. So nobody raised their hand. And the reason why I'm asking this question is that when we start forgetting names, and I have to admit that I mean, it's not that we forget, right? We have a hard time to get it out of our mouth in the right time, etc. It's very embarrassing. It's anxiety provoking. But as you see here, if it is 100% of the people who are in this forum, and I can tell you that not too long ago, I gave a presentation to 800 older adults. And one raised his hand and said he never forgets names, and I envied the mother of him. But the 799 didn't raise their hand. And what that means is that despite the fact that this is a very embarrassing phenomenon in certain circumstances and makes people think that maybe I'm beginning to develop Alzheimer's disease, the reality is that when something is as common as here, what we see, it is not a symptom of Alzheimer's disease. It is, we don't know actually what's the neural underlying mechanism for why names are the first thing that go. But it's not Alzheimer's disease. Alzheimer's disease is more profound, is when you question who the person in front of you is. In more severe stages, of course, we forget. I mean, the Alzheimer's patients may forget even the most loved ones. In the same context, although this one is a little easier, is there anyone who doesn't forget where they put their key or their glasses or their cell phone? That's a good one. Cell phone is a good one. All right. That's the same story. All right. It's annoying. It's irritating. You keep questioning, oh my God, what's happening to me? But it is extremely common. And once again, nobody raised their hand and said, no, I never forget, which means that this is not a concerning memory problem. It is an aging problem that is concerning. And if we can use tricks or whatever is necessary to diminish, like with the keys, always put them in the same place, etc., then it's better, but it's not one of those problems that we would be concerned about. All right. What about, all right, I'll give you an example. I'll ask first a question just for curiosity. Do people above the age of 90, I'll take it even more extreme. Do people above the age of 100 have the capacity to learn new material? Yes, the answer is yes, okay? Now I'm gonna take an example, I'll come back to this point. I'm gonna make up two cases that are almost identical, okay? So we're gonna, since we're women, the majority are women here, so let's pick two women. They're both 75 years old. Both of them are lawyers, so they have the same kind of education. Both of them come to us or to the doctor with the same complaint. I'm scared I'm developing Alzheimer's disease. I'm forgetful, all right? We take the first woman, we do a bunch of testing. One of the tests that we do is we build on learning to see if there is an issue, all right? So we read, let's say, 10 words, and we ask that woman to tell us as many words as she remembers, and she remembers 5, all right? I'm making up, all right? Then we read the list again for the second time, and she remembers 7, and then the third time she remembers 9. That 5, 7, 9 is a learning curve, and that's what we want to see, okay? In 100 years old, it's going to be 1, 2, and 3, all right? It's going to be just much slower and in less quantity, but you do expect to see an improvement when the person has normal cognition. The second woman, which I remind you, same sex, same education, same complaint, right? Same age. She comes in, we do the same procedure. She remembers in the first round 5 words, just like the first one. And then she does a second round, she remembers 4 words, and the third round, she remembers 5 words, all right? A picture like this is concerning for us, all right? Because we are expecting a certain learning curve, and that person was flat. That's a red light, all right? And the reason why I took the extreme example is of 100 years old, because even in 100 years old, if they have normal cognition, they will learn. Do you think that forgetting the date of an event, an important event, a wedding, a bar mitzvah, is forgetting it is a concerning memory problem? No. Okay, the answer is no, all right? For the same reasons that I mentioned before. It's extremely common. Honestly, it's also not the most important things. With an Alzheimer's patient, sometimes even in the beginning of the process, the person will forget that the party happened altogether, or if the person remembers, the party doesn't remember, the person won't remember what the party was about, okay? So the concern, the problem, the symptom is more serious, all right? So now I'm gonna go back to sharing. Let's see if I can do this effectively. Oh, that's not what I wanted. Here we go. And do you see it? Just, do you see the share? Yep, okay. So now I want to define Alzheimer's disease, and I'm going to not contradict myself, but I'm going to explain to you something that is completely new, all right, that changes this slide. I haven't put it in because it's so complex and so problematic, but let's begin by the typical diagnosis, okay? Until not too long ago, diagnosis of Alzheimer's disease was clinical, and we could not call it anything more than probable Alzheimer's disease. Because the only way of confirming that it's Alzheimer's disease would be post-mortem, would be after a person died. You would take a little bite of that brain, you would look at certain pathologies, which I'll introduce to you in a few minutes, and only then you would know definitively that it's Alzheimer's disease. So a clinical diagnosis will, and if you can mute your, thank you. So a clinical diagnosis requires a memory impairment, an objective memory impairment, okay? People coming with subjective memory complaints, like the ones that I was kind of testing you before, I don't know where I put my glasses, I can't remember names, those don't count. People are tested for memory impairment, and if they have memory impairment, it's still not enough to call it Alzheimer's disease, okay? We look for a second set of symptoms in cognition. It could be problems in orientation in space, difficulty with orientation in time, difficulty with retrieval of words, so the fluency. Many times you'll see executive functions disruption, lack of capacity of making decisions, difficulty understanding sense of humor. So we are looking for memory impairment, and if it's not a memory impairment, it might be another dementia, which I'll relate to in a moment, but it won't be Alzheimer's disease. So Alzheimer's disease requires an objective memory impairment. The other thing is that we really have to make sure that it is a clear deterioration from the original state. What do I mean by that? We had a participant while I was still at Sinai. She was 94 years old. She was the hottest 94 years old I've ever seen. She would wear pumps like this. She had no balance, but she had to look great. And she still drove. And one day she didn't make it on time. And I called to see if she's okay. And she said that she got lost. And I got very nervous. And she said, Michal, don't worry about it. My orientation in space has always been terrible, and it's not the first nor the second time that I'm lost. That, for me, is calming. What we typically get with family members is you have no idea who she was before, or you don't know how brilliant he was, okay? Statements that clearly show that compared to the past, that person had significant deterioration. The next thing that is important is a clear impairment in social, professional, and day-to-day activities. And this is very important and interesting in the field right now, okay? There is withdrawal. People who have Alzheimer's disease in the beginning, they have awareness and they withdraw. They don't want to embarrass themselves when the words don't come out and where they forget someone or something. The activities of daily living, they can be from as basic as getting complicated with closing a shirt or dripping before making it on time because the planning is incorrect to make it on time to the bathroom. The professional piece is a more new one, because until 15, 20 years ago, women were 60, men were 65, they're home, they don't work anymore. And as you'll see in my next graph, those are the ages where the prevalence of this disease begins accelerating. Today, people work until they die, right? And I'm pleased that that's the case. We had a family in our research, 4 siblings. Happy was 103, and then there was a sibling 101, 99, and 98. The 98 one, he was a lawyer together in the office with his son, grandson, and great-grandson. All right, who was 98. So that happens. And many times the feedback or the impression that something is wrong comes actually from colleagues saying he's missing meetings, or his desk was always very neat and now it's a mess. So the professional piece now has a meaning. And finally, we want to make sure that there are no other diagnoses that might be confounding the diagnosis of, or might look like a diagnosis of Alzheimer's disease. It could be B12 deficiency, although it has to be a very severe B12 deficiency. It could be a tumor. It could be a stroke. Now, before I just go into this graph, I want to do 2 things. Lori, if you don't mind, just write to yourself, if we have the time, I'm going to discuss the blood biomarkers, okay? Because there is a shift in the field from looking, all I told you now, up to now in this slide, are clinical symptoms, all right? But when someone goes to the doctor for their heart, the doctor will test the biology of their heart and will say, even if you're feeling some pain in your chest, your heart is working perfectly fine. We don't have to worry. Or alternatively, if there are symptoms and the person is tested and there is a problem, the person is immediately treated. In the brain, it's all much more complicated, right? Because it's more difficult to see what's happening inside. And this has been a major shift in the field because we're developing new methods to see the brain, to see the pathology of Alzheimer's in the brain, including methods in the blood. So because I have so much to tell you, we're going to keep that. And if at the time of questions I have time to detail more about that, I will do so. So before I get into this slide, I just want to mention something that comes back as a question quite often. What's the difference between dementia and Alzheimer's disease? For some reason, Alzheimer's disease sounds more elegant than dementia. So many times people say, oh, he didn't have dementia, he had Alzheimer's disease. And now I want to tell you that that sentence doesn't make any sense. And the reason is that there are many types of dementia. Alzheimer's disease is characterized by a specific type of pathology, which I'll show you in the next slide, so you have a feel of how the field addresses this disease in terms of the pathological processes in the brain. But there is vascular dementia, which is primarily characterized by vessel disease in the brain. There is a Lewy body disease that is usually accompanies Parkinson's disease. There is frontotemporal dementia that is characterized by another type of pathology and also has a little bit of a different clinical course. All those are under the dementia umbrella. All right, why? Because there is a neurodegenerative deterioration. The person begins a process that affects their cognition and deteriorates over time, all right? And the reason why people get confused between Alzheimer's disease and dementia is because if you take 100 people who have dementia, about 70% of them will have pathology of Alzheimer's disease in their brain. And in fact, the older the person is, so if we get brains of people above the age of 85, it's most likely a garden variety. People have almost for sure Alzheimer's disease pathology and a bunch of other pathologies. By the way, from a treatment point of view, it makes things very complicated. So dementia is that umbrella for several types of dementia, Alzheimer's disease being the most common of them. Now, here's the prevalence by age, okay? No matter what we do, no matter what risk factors and protective factors we learn of, and I'll detail some of those soon. Age is the most strong or the strongest risk factor for Alzheimer's disease. And just as an example, between the ages of 65 and 69, you get between 4 and 8 or 9% people that will have some level of cognitive impairment that is concerning in terms of dementia. And if we jump right away to people above the age of 85, it's 50%. All right. Now, this is where, well, my passion comes from many reasons, but this is one of the main reasons for the passion, right? And that at the age of 85, 20 years ago, I would ask people in an audience, do you know anyone who is 90 years old? And you get 3 people raising their hands. Today, I can assure you that all of you know people above the age of 90. So half or more than half of them will have dementia, primarily Alzheimer's disease, but some kind of dementia. As I said, it's a garden variety in the brain. And what is interesting is that in the past, we thought that if you make it to 90 and you didn't get dementia, then maybe or likely you have some protective factors. And the truth is that likely you have some protective factors, but the prevalence keeps going up and up. Not all of us will be demented if we live to 120, but the vast majority of us will if we don't change it. So here is a big problem, and there are, again, changes in the field. The field is very lively right now, so it's very exciting. So let's say in the last 12 years or so, over 460 molecules, drugs, have been tried. I don't know if you guys can, if any of you can unmute, but can someone take the risk and tell what is the amount of money that is invested from head to toes for a clinical trial to try a new medication? Just throw a number. If nobody takes a chance, I'll give the number. I'm just curious to see what people think.
$50 million.
$50 million. What else?
3 million.
3 million. It's $1 billion. It takes $1 billion, give or take, from the moment you're discovering a molecule to the moment that it comes out to the market. Now, 460 or so times we tried and we failed again and again. That's a big deal, and I'm going to get to that as well. The reason why I said until recently, because as many of you may know, the FDA has approved 3 medications, which I'll address later. 3 new medications. So I want to walk you through briefly through the different main pathologies of Alzheimer's disease, okay? You don't have to remember, it's just so you get a feel of how we are addressing the disease from a pathological point of view. So the most well-known and common pathological signature of Alzheimer's disease is this yucky thing here. This is a real human brain, by the way, as is this one. So this is called amyloid plaque. Amyloid is a protein that, for reasons that we don't fully understand, otherwise we would have addressed it, it aggregates between the neurons, okay? So in the gap between the neurons, it aggregates. Neurons you see here, there is a nice picture of a synapse. This is the gap between 2 neurons. Those 2 neurons are talking to each other. This conversation between the 2 neurons is mandatory, is necessary, okay? So if something is in between them, blocking their capacity to communicate, both sides die. Now, if both sides die, a cascade begins, right? A cascade of death of neurons begins. And those amyloid plaques, they not only aggregate, but they spread. And therefore, they are the primary pathology defining and being addressed by the Alzheimer's field. A second one is here on the right. Those are named neurofibrillary tangles. It's like this little fishy. And those are, the neuron has a shape, okay? The body of the neuron has a shape, and then it has like this little tail that is called the axon. There is a protein named tau that holds the shape of the neuron, okay? And a pathological process that, again, we don't know what triggers it, makes that tau protein dysfunctional and aggregating into those neurofibrillary tangles, and the cell collapses and dies. All right. Plaques typically come before tangles, and there is a relationship between the two. The third type of pathology is the most, I mean, the neurons are definitely the most beautiful cells of the brain, but the microglia is also a very cute cell. And those are from the lab in Israel that I worked before I came to Rutgers. And those are microglia. And actually, the orange little stains here are actually amyloid plaques. And what the microglia does is to chop it and to break it into little pieces and take it away, right? It's like a garbage truck. In Alzheimer's disease, it becomes activated. Now, microglia needs to be activated under certain cognitions. If there is a toxin, it turns on and it takes it out. In Alzheimer's disease, that activation loses control, and the microglia doesn't work well as it should. And many times when we talk about neuroinflammation in the brain, we are mostly addressing the dysfunction of the microglia. Just quickly, I'm going to say that the medications, up to the new ones that have been approved by the FDA, the medications that were, being prescribed in the last 25, 30 years are what we call cholinesterase inhibitors. So the brain has it has several chemicals, but one of them is called acetylcholine. And brains of Alzheimer's patients have lower levels of that chemical. What the cholinesterase inhibitors do is to increase that level. Now pay attention, because I'm going to explain something that is important, okay? The cholinesterase inhibitors are symptomatic medications. They work a little bit like a Tylenol. So imagine a patient whose course of decline would be, let's say, something like this, okay? If they take cholinesterase inhibitors, their course blips a little bit. Here's your Tylenol. But ultimately, it will stop function. It will stop working for that patient, and that patient will go back to the same place where he or she would have been if they didn't take that medication. The question immediately is, so what's the point of taking it? Is because that blip could be a year and a half or 2 or 3 of a family member, a mom or dad, a grandma, who still remembers who you are, who is able to enjoy life. Excuse me. The new medications, which I'll address at the end of the talk, because I know it's a polemic, it's a very important topic right now. They change the course of disease. So that same person going down like this, taking that medication, will likely go down like this. So over time, that person will decline less fast than if they haven't taken that medication. I'm moving on. In between the neurons, there are other types of chemicals, all right, called synaptic proteins. They're very important. In fact, they're crucial for the normal communication between the neurons. And we have a finding that we're very, very excited about, which I'll mention. And finally, surprisingly enough, the only place in the body that we know so far that produces insulin is the pancreas. The pancreas is over a foot away from the brain, and all the cortex, all the gray matter of the brain has insulin receptors. So if the pancreas doesn't produce insulin, the brain pays a very dangerous price, because neurons love insulin. They can't live without them. So I'll address this from a therapeutic point of view later on. So why did it take us so long to hit the goal? And even the new medications, as I'll mention later, they have many, many problems, primarily very severe adverse effects. So the first thing is that the world is kind of moving into, there are many reasons, okay? I picked a few that I think are central. One is genetic heterogeneity, right? Think of, God forbid, breast cancer. To the best of my understanding, there are about over 75 treatment protocols for breast cancer. Those treatment protocols are specific to the genetic background of the woman, if her receptor reacts or doesn't react to the medication, and a bunch of other things, if the woman is overweight or isn't, the age of the woman, the size of the, so there, you treat a woman with a particular protocol, and I'm talking about the breast. Now think about the brain. There is nothing else in the world, nothing in the universe that is as complex as the brain. And we run clinical trials as if all Alzheimer's disease patients are in the same bag of something. So I think that's the first big thing, that eventually it's not going to be Alzheimer's disease, just like once it was the disease for cancer, and now every single cancer has its very, very specific name. I think Alzheimer's is going to go in that direction. And if you remember a little bit the pathologies that I showed you, it's going to be Alzheimer's disease of the amyloid type, of the neuroinflammation type, of the vascular type. And some people will probably have a few of those and will have to be treated accordingly. The second thing is that we're not hitting the right biological target, possibly. What do I mean by that? The greatest thing of failing is that you got to get out of your box. The issue of amyloid and tau, which are the two pathologies the main pathologies that I showed before, were so central, so central in our field that we kind of neglected other pathologies. But as I showed you and exemplified for you, there are many other pathologies, and they probably interact with this amyloid and tau. So I think our failure for so many years of hitting the right button opened up many opportunities to look at other pathologies that absolutely and unquestionably contribute to the risk and to the course of disease. And finally, and this is the reason why, while I'm building up this New Jersey Alzheimer's Research Center, I am putting a great focus on prevention. And the reason is this. Let me show you. Okay, I'm going to walk you through this. Okay, this is real data, by the way. This is not a conceptual model. So here, in the dotted lines, is the graph it's more or less the graph that I showed you before. So around the age of 60, 65, there are about 5% of the people have Alzheimer's disease, possibly some other type of dementia, and the age of 85, it's going to be about half. All right. The black line is actually amyloid. And if you look, this red double arrow, what it's showing is that amyloid begins aggregating in the brain in many of us in middle age. So all those clinical trials are looking at people above the age of 60 or 65, which is 10, and the average age of Alzheimer's disease onset is 75, which is about 20, 25, maybe even 30 years after the pathology started aggregating in the brain. So I think that's another major area that we have to address. Let's talk about non-modifiable risk factors for Alzheimer's disease. I can assure you that at this point, many of you have a gazillion questions for me. I know it, I just feel it. And at the end, I can stay as much as needed. Okay, so really no stress. How am I doing with time? I think I'm good. Yeah, all right, so don't worry, because I will answer the questions. So non-modifiable risk factors for Alzheimer's disease are age, as I mentioned before. Anyone can tell me who has more Alzheimer's disease, men or women? Take a risk.
Women.
Women, yeah. Who was going to say something else? Women comprise about 65, 2/3 of the Alzheimer's patients. At this point, usually if I'm face-to-face here, the majority are women, so the joke is not going to go, but usually I have a bunch of men, right, also watching a presentation, and as soon as I say about 2/3 are women, they relax on the chair, right? They have like, it's not me. And then I remind them that they have more schizophrenia and more bipolar disorder, more heart disease, and more a bunch of other crap, so don't worry. Just for curiosity, if a disease like Alzheimer's disease has a clear preference for one of the genders, what could that mean? Please, someone just take the risk and answer what you think.
Hormones?
Hormones, thank you. All right, usually people take a little bit more of time. People say stress, people say the kids or other things, but yes, the main answer is hormones. And hormones is a complicated topic to address, and I'll tell you why. there was a big study many years ago named the WIM study, the Women's Health Initiative Memory Study. Okay, so there was a Women's Health Initiative, and the investigators in the Alzheimer's field piggybacked on it. It was a hormone replacement therapy clinical trial, big one. The women were all above the age of 65. They all had mild Alzheimer's disease, and they all were naive to hormone replacement therapy, so they have never been treated with it. And the study had to be stopped. Okay, the idea was that the depletion of estrogen, which also the brain needs, is the main reason or a main reason for a higher risk for Alzheimer's disease in women. So if you treat it, you'll decrease the risk of declining further. And they had to stop the study because women on the hormone replacement therapy had more, they developed more Alzheimer's disease and greater severity than those who did not, than the controls. And the reason seems to be that if you think well of it, when does a woman begin to take hormone replacement therapy? When is the window when women have to take hormone replacement? Is around the menopause.
Right.
The menopause does not happen at the age of 65. And the interpretation of that failure of that clinical trial is that treating women with estrogen, progesterone at the age of 65 is definitely a big mistake. Where is the problem? Why can't we run a clinical trial? Or we could, it just would take forever. I remind you, $1 billion for a regular clinical trial from head to toes. A clinical trial, and I remind you also the graph that kind of after the age of 65, you see that real acceleration of prevalence of Alzheimer's disease. If women have to be treated with hormone replacement therapy around the age of 50, how long would they have to be followed to see if they developed Alzheimer's disease? It would be a 20 years clinical trial. And therefore, that's a big issue, a big problem in relation to truly understanding if hormone replacement therapy would help women not to develop the disease. And then there is this terrible trade-off, right? Because hormone replacement therapy, although very little, but does increase the risk of breast cancer. So you say, okay, so I'm going to die of cancer, I'm not going to have Alzheimer's disease. Yay. Finally, still in the non-modifiable, there are genetics and the ApoE genotype. So there is a gene. Let me take it back 1 second, okay? There are 3 well-identified mutations that cause Alzheimer's disease. They are called APP, PS1, and PS2. All 3 of them are related to amyloid, and this is why amyloid became the main core biological feature of Alzheimer's disease. Those 3 mutations are very rare. They're about 1 to 2% of the Alzheimer's patients, and they happen very early. I believe many of you might have watched Still Alice. It was Julianne Moore, right? I think she got the Oscar for that. She was amazing, and she had a mutation. And actually, when you have a mutation, 50% of your kids will have the mutation. And in the movie, for whoever watched it, one of her daughters didn't want to do the exam, but the one that did, she was positive for the mutation. Right? Those are very rare. The vast majority of the cases, there isn't a gene that causes the disease. Today, we're aware of about 100 genes that contribute to the disease, which makes it quite complex, right? Because you might have a genotype of this kind, but not of that kind. And when you put all this together, is a real puzzle of what in the genetics contributes to your risk. The ApoE genotype has been consistently shown to be related to Alzheimer's disease. And what do I mean by that? There are 3 types of ApoE genotype, 2, 3, and 4. We get one from mom and one from dad. So you can be a 2-2, 2-3, 2-4, all the options, right? All the combinations between a 2, a 3, and a 4. People who carry one ApoE4, so it's either a 2-4 or a 3-4, are at increased risk for Alzheimer's disease by all means. People who carry both, and what's the name of Thor, of the actor that played Thor, that good-looking dude? So he is a double ApoE4, and he came out to the media saying that he knows that there is extreme high likelihood that he will develop the disease, and he's making some major changes in his life because of that. right? So it is very rare to have. It's only 2% of the population that has APOE4/4. But if you have it, then it's almost as if you had the mutation, not great. All right? And moving on. So those are the depressing, non-modifiable risk factors. Now I want to talk about the modifiable one because they're much less depressing. All right? So one of them is physical activity. The other is obesity. So lack of physical activity, of course, is a risk factor for Alzheimer's disease. Obesity, hypertension, diabetes, smoking. Those 5 are related to heart disease just as much. Okay, so if you protect your heart, you're de facto also protecting your brain. And then there are 2 risk factors that are directly related to the brain. One of them is cognitive activity, and by that I mean the real thing. All right, reading the kind of reading the news or the titles of an article or another, that's not cognitive. That's pretending cognitive activity. Cognitive activity, I really mean it. It's really sweating the brain. Is when you're uncomfortable because you have to think it through, or you have to calculate it, or you have to play it on the piano, or you have to try it in a language that you don't speak well. So cognitive activity is the real sweat your brain. And depression. Depression is a very interesting topic in the Alzheimer's field because the literature is not absolutely clear about it. There are studies showing that if you have had a true depressive episode, you're at high risk. There are studies showing that it's incipient to the disease. So a person having depression could be already the brain giving trouble there for the depression, and that kind of goes together with a cognitive impairment. About 80% of the patients with Alzheimer's disease will be depressed at some point, okay, with good reason between us. Treatments for depression so far have not been useful for Alzheimer's disease. They are useful for depression, but not for Alzheimer's disease. And I also want to mention something for those who are related to this disease. Depression in older adults looks very different than how it looks in younger people, okay? It looks in younger people, there is sadness, there is crying, there is either a lot of loss of weight or a lot of gain of weight, there is this need to be in the dark, withdrawal. The depression of older adults mainly is expressed through apathy, all right? Something as if the person is not feeling inside. I'm not going to give more attention to this right now because I still have a bunch of stuff that I want to talk to you about, and I have like 10 minutes to push a lot. Yeah, but depression is in any case, depression has to be treated because even if not directly causing or related to the disease, if a person is depressed and doesn't eat well and doesn't exercise and doesn't interact with other people and doesn't make cognitive activity because they are depressed, then they are indirectly affecting their risk. So there are 3 major clinical trials for prevention of disease. So this means they took people who do not have the disease but are at enhanced risk for the different reasons that I mentioned before. And those clinical trials, here's the interesting thing. One of them is called the Finger study. The original Finger study showed improvements. So people who were receiving interventions in those risk factors that I mentioned before, and they had a slow rate of cognitive decline. And now we're waiting very eagerly because they're the world fingers. After that Finger study was successful, there are replications all over the world. The Finger study in the United States is named Pointer study. All right. So we are waiting to get those results. Those clinical trials take a long time. Interestingly, the other 2 clinical trials, their results were beautiful for people at high risk, but less so for people with no high risk. So people with amyloid in their brain, they reacted to so no symptoms yet, but the pathology is already there. Their course of decline was delayed. People with the APOE4 genotype, still cognitively normal, they reacted well to the intervention. Now, why is this so important for me to make like listen to what I'm saying? Everyone wants a magic pill. All of us want a magic pill that will make you pretend you're skinny or make you skinny. Everyone loves Ozempic because of that. That will pretend that your body exercise and fix your diabetes and your hypertension and make you not feel like smoking. Or if you're smoking, we'll fix whatever the smoke is doing to your vessels and other things. And what I'm telling you is that's unrealistic and it's not going to happen. I mean, I wish maybe one day, but let's say in the next 50 years, I don't see something like that happening. And those risk factors are modifiable. And we're showing data that when you modify them, you modify your rate of decline. Let me see. Okay, I'm going to skip this just because I don't have much time. So I want to talk a little bit about those newly approved Alzheimer's medications. And Lori, I think what I'm going to do, I have a bunch of other slides about things that we're doing at Rutgers in terms of novelty of treatments. But I do want to leave enough time for questions. So if people ask me, show me novelties about what's happening in Rutgers, I'll show those slides, but just I'm afraid that people want to go and sleep and do their own business and they won't have a chance to ask. So 3 medications were approved by the FDA recently. All 3 of them are, notice, aducanumab, lecanemab, donanemab. MAB means monoclonal antibodies, all right? So those are antibodies that recognize or identify the pathology and, simplistically speaking, breaks it down, okay? They have, each one of them have slightly different mechanisms of action, and also the way the medication breaks down amyloid is a little different, but all 3 address amyloid. Aducanumab had 2 big clinical trials. One worked and one didn't. And we, the field of experts, were amazed to discover or to learn that the FDA approved aducanumab despite the data not being clear. The adverse events could be very dangerous, and I'll tell you about it in a moment. And in ApoE4 carriers, they can be lethal. What happened was interesting because FDA approved it, but Medicare didn't. And the physicians in the field say, we're not going to give it. We are not convinced about the data. So essentially the company itself, right, it's Biogen, they just pulled out. They said, okay, nobody's going to do this, we're out. The second one is lecanemab, which is the one that is making most noise right now, Leqembi. This is also infusion. The person has to take it, to have to come for an infusion every 2 weeks. So it's quite a bit of an infrastructure to serve the whole country. Okay, we have about 7 million patients only in the United States right now. And there is no chance that in the near future, we're going to have infrastructure for 7 million patients. Keep in mind that for all 3 medications, we're looking for people at very early stages. And the earlier the stage of amyloid aggregation, the better those medications work. All right. That's also telling you why us at Rutgers are making a point of targeting prevention rather than treatment. Donanemab is a little different of medication, has been approved recently. They're not in the market fully. I think they're not in the market yet, but it's an interesting medication. It seems that adverse events are slightly less dangerous. So as I said, those medications change the course of decline. So they don't just do the blip and get you back to where you would be. So that's the biggest change from a therapeutic point of view. The adverse events can be difficult, okay, and potentially dangerous. They're named ARIA, which is amyloid-related imaging abnormalities. That's a very fancy schmancy name to either seeing inflammation in the brain or seeing microbleeds. For certain people, especially the microbleeds, can kill them, all right? It's rare. It's rare. And those adverse events tend to happen in the beginning because think of it that those amyloid plaques, they are sticky. And you put something that is breaking them down, the brain reacts. Later on, usually people are taken out of those medications for a period and then titrated back up. And most of the time, it works well, all right? The other thing that it's an issue, from my point of view, it really fits a small proportion of the population of the Alzheimer's patients or those at high risk, right? Because the doctors are very afraid. I think with time, as we get more data, everyone is going to be a little more lax, but doctors are scared of giving it to ApoE4 carriers. You might have heard, so England, that is not the European Union anymore, the United States approved the medication for everyone that fulfills the criteria that allows them to take the medication. England had approved it, but not for ApoE4 carriers, because we know they have more adverse events. The European Union had not approved it at all. They said it's not enough data. Now the data is coming out, and they relaxed, and they adopted England's position. So they will allow to give it, but not to ApoE4 carriers. At this point, I'm just going to stop sharing. I have a few more slides, but I'm going to let go so you have an opportunity to ask me questions.
Okay, so I'm going to start up at the top with the first question. And that was, what was the difference between the green and yellow in the
graph.
Alzheimer's disease age in the graph?
So it was between Alzheimer's disease and any dementia. Okay.
Okay, and should a woman who has estrogen treatment from 50 years old, should she stop at some time, example, at like 70 years old?
So I'm not an expert in estrogen replacement therapy, and I don't know well enough. I understand that the rule of thumb, or the general rule, is to take it between 5 and 10 years, and then slowly titrate down. But I honestly, I am not an expert in this field.
Okay. And if you have a parent with Alzheimer's disease, do you recommend getting tested for the ApoE4 gene?
Okay. So let's say, give a minute to this question. It's a very important question, all right? People who have a parent with Alzheimer's disease are at increased risk. Depending on the study, it can be 4 times high risk, it can be 5 times high risk. Alzheimer's disease is not only due to ApoE4, it does increase the risk, but it's not only due to ApoE4. In the past, I would have said, we don't have good medications yet. I wouldn't test myself for that. Now that there are new medications, you might consider doing so. The downside is that even if you're an ApoE4 carrier, you might be asymptomatic for the rest of your life and live a long life without it. All right. So it could bring a layer of anxiety. And this is each person with his or her own decision process on that regard. However, I want to recommend something to everyone. I took my mom, I can tell you. And the only reason why I wouldn't take myself yet is first because I don't feel much symptoms at all, but also because I know too well how people are tested. I am very pro a baseline assessment. And what is that? I think that if you don't have any subjective memory complaint, all right, if you don't feel you have any problem, just forget what I'm saying now, because it's irrelevant. But most of us at some point begin questioning, is this normal? Is this subnormal? What's happening with me? Maybe I'm developing the disease. If you go to a memory clinic wherever you live, and you tell them, I am concerned, and they do a whole testing on you, that will be your baseline. What that means is that they have that information on you. You come 2 years later, and you say, listen, I feel that something is wrong still. They have what to compare it to. They compare, they say, looks the same to me. You go home and you're calm. If they see a change, then it can be immediately addressed. Okay, so for those of you who are above, I would say above the age of 60. Okay, if you're below the age of 50 and you feel that the age of 60 and you feel that something major is happening to you, go ahead. But if you're above the age of 60 and you feel that something real is happening to you, okay? Many times, or with this story, I never remember where I put it. I got into the kitchen and I can't remember what the heck I wanted to do in the kitchen, kind of thing. And the rest of your day is fine and productive and everything is okay, forget it. But if you truly feel that there is a problem with you, go to the doctor, do that baseline. Worst case scenario, doctor says, listen, I'm seeing something that doesn't look good to me. And then you're there ready to be addressed. Best case scenario, you have your history. And you can go home and come back a few years later to make sure that there are no changes. Next question.
Okay, so this is being recorded and we're going to share it on our AADC YouTube channel. So the next question is, if hypertension is under control with medication, is it still a risk factor?
All right, this is a really good question. Okay, there is the answer is no. When hypertension or diabetes or cholesterol are well controlled, the risk that the disease, the underlying risk, cardiovascular risk factor confers is less of an issue. With hypertension in particular, there is a very nice study, the SPRINT study, that they show that people who are people with hypertension who are very well controlled for their hypertension with medications, they actually have a low risk of developing both mild cognitive impairment and dementia. And in the last Alzheimer's Association International Conference that we were now in Philadelphia, I went to watch their follow-up presentation. And there were several methodological problems in the way they presented the data, but the bottom line is that those who were treated for the hypertension medications, because they were hypertensive, right? You're not going to go and treat your no hypertension with hypertension medications. That's not going to be good. But those hypertensive people who were treated, even when the study ended, they followed them up for another year and a half, and their lower risk was maintained. So that's a very interesting result.
Okay, and does alcohol consumption increase the risk of dementia?
It's a good question. There is a dementia named, I told you that there are many different types of dementia. One of the types of dementia is Korsakoff dementia, all right? Korsakoff, what alcohol does in high intake, okay? So you take a glass of wine every day, nothing's gonna happen. But people who are heavy drinkers, Karen is happy. I told you that the neuron has a body and that little tail, right? The axon. The axon has certain cells that are kind of around it, called the Schwann cells. Those are very, very fatty cells that what they do, they help the electric pulse to go through the axon effectively. Alcohol kills that fatty layer, all right? And that eventually can cause dementia. It looks a little different, by the way, clinically. Low amounts of alcohol don't do any bad.
So here is a question from Anna. Are women diagnosed with estrogen positive breast cancer treated with estrogen reducing drug at more risk for Alzheimer's disease or dementia?
So I don't know the answer. It's a good question. I don't know the answer. I can say one thing, that there is a relatively new phenomenon that the NIH, the National Institutes of Health, are putting a lot of money to try to address. And actually, there is a Yenyo, a very nice investigator here at Rutgers that is addressing this topic in animal models. It's called a chemobrain. So people who receive chemotherapy, the chemotherapy crosses the blood-brain barrier and does affect the brain. Most return to normal functioning and some stay fuzzy, right? Stay with some cognitive impairment that is not fully clear why. And as I mentioned, the NIH is pouring some money to try to understand that. I'm sorry, I can't respond to the question itself. I just don't know the answer.
Okay, thank you so much. And so Jean would like to know what your website is.
So it's what is the website, or what do we have there? It's a regular website with a lot of pictures and videos explaining different things, and it's ADRD. And the reason why it's ADRD, AD stands for Alzheimer's disease, RD for related dementias. Because once it was only Alzheimer's disease, but what about the people who have vascular disease? What about the people who have inflammatory disease and other things? So now it's ADRD, Alzheimer's disease and related dementias. .rutgers.edu.
Okay, I'll put that in the chat in a minute. And
that's correct.
Okay. So let's see. Does Rutgers offer a memory clinic to get tested for that baseline assessment that you had mentioned?
So Rutgers has a small memory clinic. It's growing slowly. Okay, so it's growing. I mean, let's put it this way. We're hoping that our presence is going to enhance the services. But if you cross your fingers very tightly, I'm trying to recruit a really, really good guy from NYU. He's an MD, PhD. This is all he does. This is his passion. He's a phenomenal physician. He's a physician scientist. And tomorrow is his whole day interviews. And if everything goes okay and he agrees to sign a contract, then we're going to bring him. He's going to be at NJMS just because for me, it's very, very important that we have physicians in both hospitals giving services to Alzheimer's patients or to people at high risk. So yes, Robert Wood Johnson has a growing clinic led by William Hu, and if you cross your fingers very tightly, we might have someone giving services in NJMS.
Okay, are there certain vitamins on the market there are certain vitamins on the market claiming to increase your memory? Do these work, and are there any that you would recommend taking?
Okay. So this is so complicated. Let me see how I can answer in a way that I'm going to answer questions a bunch of other people, okay? Because I know those are things that, the clinical trials for specific nutrients, vitamin E, vitamin C, combining vitamin C with E, DHA, they didn't work, okay? One of the reasons why they likely didn't work is because no one eats a nutrient. We eat a diet. We eat a combination of a bunch of things. Nobody eats just vitamin E or just DHA. So then patterns of diet started being tested. And I do want to say that there are a few clinical trials showing that people who maintain a Mediterranean diet are at lower risk of developing Alzheimer's disease. All right. So that's primarily fish, fruits, veggies, nuts, and tons of olive oil. Just feel free with your olive oil. Those are the big ones, right? There is another reason why testing nutrients is a problem, okay? We're supposed to have normal levels of nutrients. Now, when you're testing a nutrient, if you increase the level of a nutrient beyond what the body needs, the body gets rid of it. Now, it causes an ethical problem. So let's pretend vitamin E, okay? So if you bring people who have normal levels of vitamin E, you can treatment them as much as you need. It's not going to get anything better because they have normal levels. So you would have to bring people with deficiency in vitamin E. But if you know that someone has a deficiency in vitamin E, you can't not give them supplementation. You can't know that there is a problem and say, I'm not treating the problem because I want to do a clinical trial. So in that sense, the whole issue of nutrients becomes a big issue. Go ahead. I hope I responded.
Are there places, regions around the world where there is less dementia and Alzheimer's disease due to location, lifestyle, and diet?
Mm-hmm. So, I'm sorry, I keep saying this is a good question. I really mean it. It's just, I'm not a parrot. All questions that have been good questions. So the answer is the blue zones have less dementia and they have less mortality as well, right? People just go to sleep one day and then they die, right? With no dementia and relatively healthy and a very, very old age. People ask me, for example, since fish has a lot of polyunsaturated fatty acids, which supposedly do good to the brain and to the body in general, people ask, for example, if Japan has less Alzheimer's disease than other countries because their nutrition is very strongly based on fish. And the answer is that no, because Japan has a bunch of other crappy things. For example, they smoke much more than the Americans, all right? And smoke, as I mentioned. So it is very complicated to take a country and say, oh, this country, everyone eats in a particular way, or everyone is skinny and exercises, etc. It's very difficult. I do want to say, which is not what the person who asked wanted to hear, but the one place that has less dementia is actually Africa, and for the wrong reasons. The reason why Africa has less dementia is because they don't live long enough to have it, okay? And with all the millionaires pouring money into saving lives in Africa, which we bless them again and again and again, right? We want people to have a good and long life. The world is turning into what's going to happen there in terms of dementia epidemic. it's going to be an epidemic. There is plenty of drug use there, terrible nutrition, lots of poverty, a bunch of risk factors. And the longer they live, the more we're going to have work.
Okay, so the next two questions are a little similar. So I'll go with the first part of it. Does hearing loss affect Alzheimer's disease? And does hearing loss along with tinnitus increase the risk of Alzheimer's disease?
Okay. So tonight, I think, I mean, I call it tinnitus, but maybe it's tinnitus. I say tinnitus.
I
So
probably said it
tinnitus
wrong.
has nothing to do with Alzheimer's disease, okay? And with regard to hearing loss, it's a very good question again. And the less you have external input, the less the brain is being triggered, right? And we said cognitive activity is very important. So in that sense, there is some literature suggesting that hearing loss is a risk factor. There isn't enough literature showing that that the loss of hearing per se causes pathology of Alzheimer's disease. So it is suggested at this point, with the knowledge that we have so far, that simply the lack of input increases the passivity of the brain, we'll call it this way. That said, there is a young, beautiful woman here at Rutgers. Her name is Kasia, and don't ask her last name because it has 17 consonants, one after the other. I can't pronounce it. She can't pronounce it. But she's wonderful. And her passion, she does animal models, is a certain reaction to a hearing trigger or to a sound that is the very first basic reaction to of the brain to any external noise, all right? It's actually very low in terms of the brain development. And she has some data showing that Alzheimer's animals and Alzheimer mice look completely different than normal mice in that very signal. It's a signal that we're not aware of. It's a signal that a doctor cannot know without testing it technically. So I don't know the answer yet, and she put a grant together to ask that question, and that might be an initial suggestion that there are certain areas in the hearing that might be related to the disease from a biological point of view.
Okay, and is there any effect on Alzheimer's disease from the new weight loss drugs like Ozempic?
Very good question again. So Ozempic and tirzepatide are the new, right, the medications du jour. Yeah, I'm not an endocrinologist in any way, but we do have a clinical trial, which when we're trying semaglutide, which is Ozempic. Ozempic is given it's given in an injection, and we're giving it in pills because older adults should not lose weight or should not lose a lot of weight. Losing weight in old age is a risk factor for death. Okay, so for older adults, they should maintain they shouldn't lose weight dramatically in any case. Our study is actually a clinical trial that is funded by the Alzheimer's Association here in the country, and under a system called Part the Cloud. They give money to clinical trials that are outrageous, that are out of the ordinary in terms of what they are addressing. So we are actually, I remind you that the brain needs insulin, and those medications like Ozempic, they increase insulin sensitivity, and we believe that they also increase insulin sensitivity in the brain. Yeah, so we're giving that combined with intranasal insulin. I'm not going to explain exactly why we decided to do that. In animals, in humans, it's still ongoing. There is one big study led by Tali Zuckerman, who is a colleague, a wonderful colleague, and she's an endocrinologist, that she piggybacked cognitive outcomes into a big trial of dulaglutide, which is a similar medication to Ozempic. And she shows that those who were on the clinical arm, on taking the meds, they had 15% less decline than those who weren't. So that's one signal that this seemed to be good. And also in this last conference that I mentioned before in Philadelphia, there was a whole session only on those types of medications. They're called GLP-1 receptor agonists. And the data looks very good in animals and cells. I remind everyone, we have cured gazillions of mice. Okay, so we don't know yet.
Okay. And could you please repeat what you were talking about with in relation to olive oil?
It's just that olive oil is an antioxidant, and we have a study. So high level, I mean, having a lot of olive oil seemed to be one of the major contributors within the Mediterranean diet to brain health.
Can a person with aggressive Alzheimer's get treated in your clinic?
So first, remember, I am a scientist. I'm not an MD. I'm a PhD, so I don't treat. I study. All right. I develop treatments. I hope that someone else will use them appropriately. So any memory clinic will is supposed to take any Alzheimer's patients, even if they're aggressive. Aggressive, I mean, even if the course of disease is aggressive.
Okay. And how does vitamin B12 deficiency affect Alzheimer's disease or dementia diagnosis?
Okay, so this goes back to the question about the nutrients. The clinical trials on supplementation of B12 have not worked. Okay, they did not improve cognition. They did not decrease the risk of developing further cognitive decline. We can't assure that it's not because we had to treat people with normal levels of B12, because if someone has low levels of B12, you have to clinically give something to him or her.
Okay. Is there a certain type of exercise better for prevention? For example, cardio versus weight training?
Okay, so that's very good too. The answer is that it's very similar to what the heart wants. Okay, so it's very different to what you need to give cardiovascular health. It's both. All right. There is data showing that aerobic exercise is the most important one because we pump oxygen, and when we pump oxygen and the blood flow in the brain improves, we clear toxins, and many good things happen in the brain. However, the body with age tends to develop something named insulin resistance. Okay, so insulin takes glucose and gets it into the cells of the body. That's the job of insulin. And with time, the cells kind of resist insulin, and then the pancreas have to produce more and more and more and more insulin in order to get the glucose into the cells. If it doesn't produce enough of, the person becomes diabetic. There is a lot of sugar in the blood. Now, why am I saying that? The muscle is the biggest eater of glucose in the body. Muscles love glucose. So when you build a lot of muscle, then you increase insulin sensitivity because it takes the glucose very efficiently, and insulin doesn't have to do a hard job.
Okay. So can cognitive activities such as puzzles, games, and crafts help the brain?
All right. So it is very hard to have a clinical trial that is very well controlled for those things. But those prevention trials that I mentioned that were mostly successful, not fully, but mostly successful, part of what they gave people, they control blood pressure, they control glucose, they enhance the amount of social activities, etc. But they also increase the amount of cognitive effort and activity. So I would wholeheartedly and warmly recommend the more you do, the better. You know, typically, I think throughout life, we keep saying, you know, go with your comfort zone. I think until we get to the age of 60, and the age of 60, my recommendation is get out of your comfort zone.
Okay. So something like starting to learn a new language or learn the piano or something really.
Absolutely. Just something that makes you sweat. I'll tell you, I'll share you personally that since I believe my data, I started learning Italian, and I'm actually speaking quite well.
Okay, that's really interesting. And okay, so the next question is, does participation in activities with a group, such as the AADC here, help prevent Alzheimer's disease?
So I'm going to answer in a few levels, okay? When you're in a group, you don't feel lonely, all right? Or you feel less lonely. Sometimes we can be with 100 people and still feel lonely, right? It's a subjective feeling. But usually people have a nice social life, and it doesn't have to be a big group, by the way. It could be one person that you enjoy being with. But loneliness is a risk factor for everything that is bad in old age, including dementia. we don't know what the mechanisms behind it. Okay, it could be from as technical as that someone lonely doesn't take the medications right or gets to the doctor too late, to certain hormones and chemicals that are released in the brain when we feel lonely that might trigger more pathology. A whole range of possibilities. So in that sense, having group activities like the ones that you have here is a blessing. Okay, it's a blessing. And the other thing is that activities like you do now, like these, require that you think, that you ask important and interesting and intelligent questions, which is cognitive activity.
Okay. So now we do have a few minutes if you did want to show some of your slides that you didn't get to go over.
All right, someone is asking about
Oh.
sleep, so let me give that a minute, and then I'll put a couple of slides and I'll just run you through, just so you get a feel of how the research in this field moves forward. Okay, so I'll give you just a tint of it. So just in response to sleep, poor sleeping is a risk factor for Alzheimer's disease. There are several different types of poor sleep. So if someone is suffering from poor sleep, you should go and have a sleep study and try and understand what's the origin of it. Sleep medications are a complicated topic, okay? Because on the one hand, it makes you sleep, which we know is important. And on the other hand, it increases risks of falls, it increases risk of confusion. So there is a little bit of a trade-off there. People with big bellies have sleep apnea. They don't even know they're having it. They wake up 100 times a night. They're tired all day. They're at high risk. Sleep is something relatively easy to treat. And if you feel that you have a sleeping disorder, please go and treat yourself. So in general, the answer is yes. I'm going to bring up this thing. So thank you for your patience. And let me just share. And where was I? This one. Let's see. Yeah, I think this is. Let me see if. All right. So I want to mention a few. I'm going to do it quickly because I know everyone wants to go by now, but just so you get a feel, okay? We want to, I showed you that graph that shows that pathology of Alzheimer's disease begins evolving in the brain 20, 30 years before the clinical symptoms begin showing, right? So how would we know that something is happening? And this is where the word biomarkers became a hot word. Okay, so biomarkers are typically blood markers. That can be other types, but they're typically blood signatures that move together with the pathology, all right? But you don't need to see the brain. You can measure them in the blood. And if they are going in a particular direction, that would likely mean that there is a bad activity in the brain that you should be addressed, even if you're completely asymptomatic. So we are very much into omics, okay? And most people know the word genomics. So if in the past we looked at one gene or at one protein or at one, let's say, glycan or at one lipid, today the technology named mass spectroscopy can really take from a tiny, tiny bit of blood. The mass spec people ask me for 5 microliters, nothing. And then they can have the whole genome and the whole transcriptome and the whole proteome, everything. And then a whole new field is evolving, which is the bioinformatics, because then we look at a person not as one single pathway, but as a system. So we're doing a lot about that. And actually now I got some philanthropy money to do something that I'm so excited about. I feel like a child who received a beautiful toy. Yeah, but we're going to collect bloods from our participants, and we are going to induce from bloods neuronal cells. Okay, so we're going to make from blood brain cells that represent the cells of those participants. And on those cells, we're going to learn about how they function and the neurophysiology, but also what are the omics, how all those different types of systems work in the level of the brain cell, remember, from blood. And we have data on their social determinants of health and lifestyle and all those risk factors we spoke about. And we're going to relate how their neurons that were derived from their blood relate to their day-to-day life. So this is one. The second one, remember that I showed you that beautiful 2 neurons, and I said there are those synaptic proteins that are crucial for the conversation between neurons. So you don't need to remember this very, naughty acronym. It's neuronal pentraxin 2, but we have some very cool data showing that high levels of this in the brain are related to less cognitive decline, even in the presence of amyloid. So even if you have other pathologies, if you have high levels of this, your decline is less severe. Now this is the beginning. We have now a pipeline of like 7 experiments that we're going to be doing with different people in the different labs in the country to see if this is going to converge into something that has a therapeutic potential. I'm going to skip this one's collaboration with Harvard that is very, very cool and nice, but I'm going to skip just not to overwhelm you. And I did mention this clinical trial that we're doing. Remember that I said, at the end of the day, there are going to be people that will have Alzheimer's due to I'm going to stop the share. It's just so I can see you guys, that there'll be different pathologies. And as I said, 85 years old and above have a garden variety, and they are at the highest risk of dementia. So our intranasal insulin plus Ozempic trial is then actually trying to address a few pathologies in the brain at the same time. So this gives you a feel of the breadth of what one can do with a very clear focus on the patient. All right. So our center is in fact 100% dedicated to the person. We don't do research for the fundamentals of research. We do research to cure, to treat. That's it.
Okay, and somebody asked, so I think your other slides, is that kind of like good versus bad cholesterol?
The HDL and LDL. So cholesterol is actually a kind of a disappointment for me. There was, first of all, high levels of cholesterol in midlife in general. Risk factors in midlife, their potential to harm the brain in late life is much stronger than if those risk factors begin only in late life. So in late life, having some high blood pressure, some cholesterol, the doctors are likely going to treat it, but not as aggressively as in midlife. So high cholesterol in midlife is related to high risk of dementia in late life, but not so high cholesterol levels in late life. It's similar to BMI, by the way, to obesity. Obesity in midlife is a mega risk factor. In late life is less so. We don't know exactly why, but it's likely because people who have higher cholesterol, old people tend to change their nutrition into something that is a little less rich. So when you have higher cholesterol in old age, it might simply be reflecting that you have more meat and more eggs or whatever. It's something that is good for you. The disappointment is that because of this association, there were numerous clinical trials testing statins. Statin, for whoever of you has a high cholesterol, is likely being treated by a statin. And those are medications to decrease cholesterol. And the clinical trials on statin, in contrast to the blood pressure medications that I mentioned before, that there is a nice clinical trial showing positive results on cognition, the statins trials, the trials on cholesterol medications, zero, nothing.
Wow, it's also interesting and important. And I mean, some of the things you have talked about are just mind-blowing. And I thank you so much for sharing your knowledge and your expertise on such an important subject. I cannot thank you enough.
Wonderful. I hope everyone enjoyed and that it was interesting.
Absolutely. And as someone who, I mean, I know so many people who have a loved one going through this, and I myself do. So it's even going to the doctor's visits with them, you don't really hear things like this. So it clears it up and makes it more understandable. And I thank you so much for that.
Sure. My
I'm
pleasure.
so glad you could share that with